Good afternoon, everyone. Welcome to today's webinar, and thank you for joining us. My name is Deanna Hoelscher, and I'm the founding director of the Michael and Susan Dell Center for Healthy Living at the UTHealth Houston School of Public Health in Austin. Today's webinar is hosted by the Michael and Susan Dell Center. The center's vision is healthy children in a healthy world, with a mission to advance health and healthy living for children and families throughout early and impactful interventions. And as you can see, the Texas Collaborative for Healthy Mothers and Babies, or TCHMB, really fits nicely within that vision and mission. So I would like to thank the Michael and Susan Dell Foundation for providing funds to the center to host today's webinar. And I'd also like to thank the Department of State Health Services for their funding of TCHMB. The next slide. Information about our center's work and resources can be found online. Please scan the QR code on your screen to access any of our health resources. The slides for and a recording of today's webinar will be archived on our website as well, msdcenter.org. If you have any questions during the presentation today, please enter them into the questions box, chat box, for the Q&A session at the end of the webinar. And so with that, I'd like to introduce our first panelist, and she will introduce the other two panelists during her part of the presentation. So with that, I'd like to introduce Dr. Charleta Guillory, who is the current TCHMB chair. She was elected chair after serving as co-chair of the neonatal committee for 6 years. She is a professor of pediatrics in the section of neonatology at Baylor College of Medicine and director of the Texas Children's Hospital's neonatal perinatal public health program. Additionally, she is the chapter chair president of the Texas Pediatric Society of the American Society of Pediatrics. Dr. Guillory earned her MD degree at Louisiana State University Medical School in New Orleans. She completed her pediatric residency at the University of Colorado Medical Center and Louisiana State University and pursued a neonatal perinatal medicine fellowship at Baylor College of Medicine's Department of Pediatrics in Houston, and she earned her Master's of Public Health from our UTHealth Houston School of Public Health. She is board certified in both pediatrics and neonatal perinatal medicine and has won numerous awards for her work in this area. So it is my pleasure to hand it over to Dr. Guillory.
Thank you, Dr. Hoelscher, for highlighting the important work of our collaborative. The Texas Collaborative for Healthy Mothers and Babies, or TCHMB, is a state perinatal quality collaborative, or PQC. PQCs are state or multi-state networks of teams working in joint effort to improve the quality of care of mothers and babies. All 50 states and Washington, D.C. have PQCs. These collaboratives are housed in several different types of organizations, including the state health departments, academic institutions, nonprofits, and hospital associations. PQCs partner with hospitals, providers, nurses, patients and families, and other stakeholders. They use data-driven, continuous quality improvement to, number one, spread best practices, number two, reduce care variation, and three, optimize resources. Ultimately, the goal of PQCs is to make measurable improvements in population-level outcomes in maternal and infant health and achieve optimal system-level change. The next slide, please. Here is a map showing how different PQCs are funded. As you can see, Texas is funded by the CDC. It's also funded by the Texas Department of State Health Services. These PQCs, like TCHMB, all work to improve the quality of care for mothers and babies. Many PQCs are part of the National Network of Perinatal Quality Collaborative, which is a dedicated partnership between states. The next slide, please. I want to provide a brief history of TCHMB, but before I do that, I will share with you the collaborative's mission and goals. Next slide, as well as our strategies for accomplishing these said goals. Here in Texas, we're on a vital mission to transform maternal and infant health care. Our focus is simple, but powerful. We want every mother and every baby to receive the highest quality care, regardless of who they are or where they live. We're tackling the challenge head on by bringing together healthcare providers, community leaders, and most importantly, the mothers we serve. Their voices and experience guide our work as we focus on preventing preterm births, reducing complications for mothers and babies, and eliminating the health disparities that have persisted for far too long. Our approach is comprehensive, from improving healthcare environments to strengthening family support systems. We believe that by working together, we can create a Texas where every pregnancy is safer, every birth is healthier, and every family has the support they need to thrive. TCHMB is, at its core, a commitment to our communities, our families, and our future. Next slide, please. At the heart of our strategy are high impact quality improvement projects that tackle our most pressing health priorities and ensure every family has access to excellent health care, regardless of their background. To make evidence-based decisions, we continue to develop robust data systems that guide our improvement and measure our impact. We've also created a strong governance structure that brings together key stakeholders and ensure good stewardship of our resources. And we are continuously working to improve the structure to better support Texas families. What makes our approach unique is our commitment to learning from those who matter most, the mothers and families we serve. Their voices are integral to our leadership and decision-making. We combine their invaluable lived experiences with evidence-based educational resources and strong partnerships across the healthcare system. Together, we're not just planning the change, we're making it happen, project by project, partnership by partnership, for every mother and baby in Texas. The next slide, please. The history of our organization is really the foundation of which we build our future. TCH origin began 12 years ago. It originally started as an infant mortality reduction initiative at the Texas Department of State Health Services, focusing on non-medically indicated deliveries before 39 weeks of gestation, and an antenatal corticosteroid pilot to reduce neonatal morbidity and mortality. These first two projects provided the impetus to broaden the scope to address emerging perinatal health issues in Texas, and the collaborative began operation at the state perinatal collaborative in 2013. I just would like to point out two quick things in this history. Please note that one of our first neonatal projects, it was in 2016, but it only had 15 hospitals at the time, which was very early on, but we were able to make a significant impact in increasing human milk production in the NICU. In 2018, of course, we were able with 15 hospitals at that time to improve maternal early warning system and working with Texas AIM. Well, in 2020, we started working on the neonatal admission temperature project. And if you notice there, we had over 161 hospitals participating in that particular project, making a big dent in the state of Texas. And a lot of that, plus the PPAD project, which we'll discuss later on, and that's the recognition and response of postpartum preeclampsia in emergency departments, that increased to 41 hospitals participating. But what happened in 2019 was that the collaborative integrated with the RAT PCR Alliance, allowing us even more collaboration across the state and improving the number of hospital participation. Here you can see that in 2022, we received a 5-year grant from the CDC, helping to work on health disparities within our infants. TCHMB has transitioned institutions twice to better support the work. First, we moved to the University of Texas Health Science Center at Tyler and worked in partnership with the UT system. Most recently, in 2023, we moved to the UTHealth Houston School of Public Health in Austin, where TCHMB is currently housed. With this move, the collaborative family and child health expertise and brought additional public health expertise to the work. We are one of only a few PQCs in the US operating within a school of public health, uniquely positioning our work within the broader public health landscape. TCHMB is proud to be a statewide network of clinical and content experts collaborating with perinatal hospitals across the state. And now I will turn it over to Dr. Patrick Ramsey. Dr. Patrick Ramsey is Chief of the Division of Maternal Fetal Medicine, Director of the Stock 1 Maternal Transport Program, and Maternal Medical Director of the University Hospital Level 4 Maternal Center at University Hospital UTHealth San Antonio. Dr. Ramsey completed his medical school training at the University of Wisconsin School of Medicine and residency training in obstetrics and gynecology at the Mayo Graduate School of Medicine in Rochester. He completed a fellowship in maternal fetal medicine at the University of Alabama in Birmingham. He also received a Master of Science in Public Health with emphasis in epidemiology, international health. He is certified by the American Board of Obstetrics and Gynecology in obstetrics and gynecology and in maternal fetal medicine. Dr. Patrick Ramsey, I turn it over to you.
Thank you, Dr. Guillory, so much. And thank you all for being here today. I'm going to be talking a little bit about the TCHMB key partners, but as we start to talk about that, I think it's important to understand the core infrastructure for our collaborative. The collaborative is governed by an executive committee, which consists of 30 members. It's led by a chair, Dr. Guillory, and vice chair, Dr. Gong. 13 members of the executive committee are voting members, and we have 13 non-voting or ex officio members, which represent other organizations and agencies around the state of Texas, not only governmental agencies, but also patient advocacy agencies and entities as well. We have 6 representatives that are from the March of Dimes, Texas Department of Health, State Health Services, HHSC, Department of Family and Protective Services, the UT Houston School of Public Health in Austin, and the UT System Administration are also part of that group. We have 2 voting members that serve as members at large, and then there are co-chairs from each of the 4 committees of the TCHMB, which also serve as voting members on the executive committee. And they all are goal-oriented to lead the direction of the work for the collaborative. In addition to the functions of the executive committee, we have 4 committees that contribute to the quality improvement initiatives of the collaborative. These committees include 1, the obstetric committee. Within that committee, we have 2 co-chairs, 1 maternal representative from each of the 22 regional advisory council or RACs, and we have 3 additional ex officio members as part of the voting composition of that committee. The OB committee initiates, coordinates, and implements the maternal QI initiatives for the collaborative. The second committee is the neonatal committee, and it has a similar infrastructure to the obstetric committee with 2 co-chairs, 1 neonatal representative from each of the 22 regional advisory council, and 3 ex officio members. The neonatal committee initiates, coordinates, and implements the neonatal QI initiatives for the collaboratives. The community committee is the third committee. It consists of 2 co-chairs. However, the members of this committee are selected from members at large and stakeholders throughout the state who represent different facets of community care. The community committee initiates, coordinates, and implements the QI initiatives related to community for the collaborative. And within the community committee, we also have a race equity group working on initiatives for the collaborative and ensuring that all of our QI initiatives have the appropriate lens for race equity and inclusion as part of our work. The last committee we have is the data committee, and also consists of 2 co-chairs and additional selected members that are elected to serve on the committee. The data committee oversees the development and the data infrastructure for the collaborative. There are a number of key partners which inform and contribute to the activities of our collaborative. These include Department of State Health Services, the Texas AIM program, the Texas Morbidity and Mortality Review Committee, the Perinatal Advisory Council for the state of Texas, the Regional Advisory Council PCR Alliance, patient and community advocates, and additional stakeholders and collaborators. We have nearly 200 individuals who bring a voice to the collaborative to inform the processes and QI initiatives that we undertake. In addition, the TCHMB regularly engages in a number of cross-state partnerships, such as the Big 5 PQC, which includes California, Texas, Illinois, Florida, and New York, the National Network of Perinatal Quality Collaboratives, and other state PQCs. So as you can see, the reach of our collaborative is great, not only within the state, but throughout the country. And with that, I'll hand it back to you, Dr. Guillory, to introduce our next speaker.
Okay. Now to discuss how TCHMB fits into the broader maternal and child health landscape. It is my pleasure to introduce to you Dr. Manda Hall to share her perspective. Dr. Hall was named the Associate Commissioner of Community Health Improvement at the Texas Department of State Health Services in October of 2017. In this role, Dr. Hall oversees and provides strategic direction to 4 sections within the Division of Maternal and Child Health: environmental epidemiology, disease registries, vital statistics, and health promotion and chronic disease prevention. Prior to this role, she served as the interim Associate Commissioner for Family and Community Health Services. Dr. Hall graduated with her medical degree from Texas A&M University Health Science Center College of Medicine and completed her residency and fellowship at the University of Alabama at Birmingham in internal medicine, pediatrics, and allergy and immunology. Dr. Hall is a past president of the Association of Maternal and Child Health Programs and graduated May of 2014 as a fellow in the Maternal Child Health Public Health Leadership Institute at the University of North Carolina at Chapel Hill. Dr. Hall, I turn it over to you.
Thank you so much, Dr. Guillory, and it is wonderful to be here with everyone. As Dr. Guillory shared earlier, if we can go to the next slides, please. The TCHMB actually began at DSHS over 10 years ago and continues to be a key initiative funded by the Department of State Health Services within our Healthy Texas Mothers and Babies program. The HTMB, our mission is to improve maternal and infant health and safety by advancing quality care, implementing evidence-based prevention, and addressing health disparities for all Texas mothers and babies. We do this by focusing on 5 programmatic areas: individual and public awareness and knowledge, professional education, community empowerment and community improvement, and the Perinatal Quality Improvement Network, or PQIN. Along with the TCHMB, the PQIN includes other programs such as the Maternal Mortality Review Committee. This multidisciplinary committee reviews cases of maternal deaths to develop recommendations to help reduce the incidence of preventable pregnancy-related deaths and severe maternal morbidity in our state. These recommendations drive programming at DSHS and the TCHMB, such as our Texas AIM Maternal Health and Safety Initiative. Through this program, hospitals implement safety bundles aimed at top causes of preventable maternal deaths, such as obstetric hemorrhage, severe hypertension in pregnancy, and mental health and substance use disorder. Through our work with the TCHMB, hospitals have been provided additional resources and support around maternal early warning signs and the role of emergency departments in caring for pregnant and postpartum women. We are looking forward to our partnership and continuing to grow as we kick off the Texas AIM Sepsis Bundle at the end of 2024. So now I will turn it back over to Dr. Ramsey, who's going to share some of the lessons learned over the last 12 years of the TCHMB.
Thank you, Dr. Hall. My camera's going back on. So as we've moved forward through the collaborative since our inception, with each QI initiative, we've strived to improve not only the reach of our collaborative, but the efficiency and the impact of the projects. Through this evolution, a number of lessons have been learned, which help guide us into the future. And I'd like to share 5 of those major ones that really truly stand out to me. Number 1, mission driven. It is critical for the success of any QI initiative that we have to have a clear understanding of what we are trying to achieve and within what time frame. And that's the AIM statement that we often talk about in quality improvement. Starting with the why is critically important. Projects identified must be clearly aligned with the collaborative mission goal, clearly defined processes, outcome, and balancing measures, and it has to address an important opportunity for improvement. And these opportunities of improvement are identified through various avenues, through the CDC, data metrics that are reported, through findings from DSHS, from recommendations or findings from the American Academy of Pediatrics, Texas Medical Association, the American College of Obstetricians and Gynecologists, AWAN, the Perinatal Advisory Council, the Texas Morbidity and Mortality Review Committee, and other sources. They all form the basis for how we identify projects that we should be looking at to improve care for moms and babies throughout Texas. Second lesson learned is know before you go. And key to every initiative for the collaborative it's embarked on is understanding what processes are currently in place at a participating partner, facility, or community entity, including what is working, what is not working, and what elements to potentially have success are missing. To inform each project, we conduct a baseline assessment of facilities to explore each of these facets. From this assessments, gaps and areas of greatest need are identified to help with project development. Learning sessions are developed and project implementation is set forth. From this assessment, we can identify high-performing facilities that often serve as part of the learning session leaders to highlight those best practices and share resources with other facilities that are trying to develop their processes and improve their care. The third lesson learned is stakeholder buy-in and avoiding assumptions. Critical to success of any QI initiative is gaining early stakeholder buy-in from all areas that may contribute to the success of an initiative, and importantly, avoiding assumptions related to knowledge or processes that may or may not be in place. And a really excellent example of that is the recent postpartum preeclampsia emergency room department project. We learned a lot of lessons from this. The project was designed to improve the detection of blood pressure complications in the postpartum period for women presenting to the emergency room. Obviously, engagement of the emergency department is a critical part of this initiative. An early inaccurate assumption from our obstetric side was that the ED regularly inquired about pregnancy or recent pregnancy status. That was an incorrect assumption. As part of this project development, we brought in stakeholders not only from the obstetric side, but within the emergency room department to explore what processes were in place currently and how could we improve those processes to improve identification of pregnant or recently pregnant patients. We also engaged leaders from the Regional Advisory Council and the perinatal care regions, or the PCR Alliance, as both are part of the state trauma and perinatal systems, to reinforce the critical opportunity for improvement and to enhance the reach and impact of this initiative. By getting this broad stakeholder buy-in and overcoming those assumptions we originally had, this project has been very successful. Lesson number 4, share and borrow shamelessly. Participants in TCHMB quality improvement initiatives come from projects of at different levels. Some have developed advanced processes for their quality improvement related to a given initiative, while others may be in early development or haven't even started to work on the initiative. This presents an exceptional opportunity to share best practices and resources among facilities rather than completely reinventing resources locally. The recent neonatal admission temperature project is an excellent example of this sharing and borrowing. Some facilities had robust processes in place for improving neonatal temperature on admission, where others were just beginning to look at that. These facilities that were higher performing facilities shared their resources and expertise with those centers developing their initiatives, and that sharing led to the broad reach of the program and ultimate success. And last, lesson number 5, data drives everything. Edward Deming, the father of quality improvement and total quality management, coined the phrase, without data, you're just another person with an opinion. Data is critically important to inform what we do and to allow for robust PDSA cycles for any QI initiative. Clearly defined, impactful data measures are developed for each collaborative initiative, and these include process, outcome, and balancing measures. As these measures are developed, care is taken to avoid data collection burden. If something is already collected through another mechanism, we don't recapture that through a new data field. We do pilot testing of data collection to ensure that the measures are able to be readily captured, collected, and reported and not incur additional excessive burden on the facility. And last, we ensure that we capture only those data elements that are truly critical to the initiative and avoid collecting unnecessary data that will incur additional burden on the facility's data management team. So these 5 lessons have greatly advanced our ability to function as a collaborative and advance our care for moms and babies in Texas. And we continue to improve on this as we go forward with learning additional lessons as we move forward. And we'll go on to the next slide. And this is a group discussion kind of looking ahead. And I'll invite all my co-panelists back today. And I think we've already heard that one of the next big state initiatives will be the sepsis bundle through Texas AIM, and we're anticipating that TCHMB will be a part of that initiative as that goes forward. And I'll open up to my co-panelists for further discussion.
Thank you so much for all of you participating in this. So I have a few questions to kind of get us started, and we can go from there. If you have a question, please put it in the question chat box and we'll get to it. So I'll start off with Dr. Guillory. What are potential gaps that you see in neonatal health or neonatology in Texas? So what do you see as important areas that we need to focus on?
Well, first of all, I would love to say that Texas and the different programs that we have working with the Texas Department of State Health Services, we have really made a lot of progress. So I want to say that first. In terms of any gaps and other things that we can do, I see that we can do things that are already in place and perhaps actually improve them. One of the things I'd like to mention is we take care of 400,000 deliveries in the state of Texas. Approximately 20% of those babies, depending on your institution, will spend some time in a neonatal intensive care unit, depending on which unit you are in. These are the highest risk infants, and these are the babies that we really have to make sure when it is time for them to be discharged, that we have a developmental follow-up. In addition to their medical home, of course, we need some sort of way that we are able to follow these high-risk infants and to make sure that they get the care they need. We've already talked about ECI and the first 3 years of life, but these babies are the highest risk ones and they tend to fall off the cliff. So we need to make sure some sort of way that funding is in place for that group. The other thing I am really would like to say that Texas is leading in, and that's the designation process for levels of care. It is so, we have done such a great job with both neonatal and maternal levels of care, but what we are also doing is showcasing Texas to other states. We now have other states who want to do the same designation process. And I think this is important because how you sell yourself to the public and how you present yourself to the public is important. If you're a level 4 unit, the public needs to know that. If you're not a level 4, you should not be presenting yourself as a level 4. So I think this is important, and the work we've done is being showcased across other states. The other thing I think, and we're working on a lot of that now, and that is Texas is a huge rural state, and we have to get more neonatologists. We have a lot of neonatologists in Houston and Dallas and San Antonio and Austin, but we need to incentivize other neonatologists to go into the rural areas so that we don't have barren areas where there's no neonatal care. And then the last thing I want to say, the last thing I want to say is that we have done great work with the collaborative. I mentioned briefly about the CDC grant, but as we look at all of our quality improvement projects, we're now looking at them with a health equity lens. And I think that's important. We did the neonatal admission temperature project, and some people may say, oh, we've done that before, but this time we looked at it a little differently. And we had a huge participation in terms of hospitals across the state. And when we looked at it, we were able to find other things in terms of results that we didn't expect, in terms of one group having more problems with admission temperature than others. So I think it's important to look at all of our work through a health equity lens. Those are the basic things, and I'm sure I've forgotten some.
Thank you. I appreciate that. And Dr. Ramsey, I'm going to ask you the same question, but geared toward maternal health in Texas. So what are the gaps you see?
Yeah, well, I think we, obviously, as Dr. Guillory mentioned, the rural health side of things is a huge opportunity and challenge. Our geographic expanse is greater than almost every state, minus Alaska. So reaching those rural facilities, we've seen some maternal facilities close in the rural areas, creating significant challenges and barriers for patients to access care, to the point they may have to travel for several hours, multiple hundreds of miles to get to a maternal facility. I think the designation process in the state of Texas has created some infrastructure to improve that. One of the things we've done through the collaborative that I think was really important several years ago was, as the designation process became implemented in Texas for neonatal in 2018 and maternal in 2021, that the leadership of the collaborative brought in the representatives for each of the regional perinatal, the regional advisory councils, the perinatal committees, to be part of the obstetric and part of the neonatal committees, so that each region of the state had a strong voice at the collaborative level to bring up ideas that may be emerging. And obviously some RACs are urban, but there are many that are very, very rural. And having that voice at the table for our discussions and deliberations will help inform and kind of laser focus us on what those needs of those rural areas may be. As mentioned, focusing on the race, ethnicity, and language breakdown of our data is very important. I think that's an area that many facilities in Texas are just starting to look at data that way. I know through survey processes and data collection through our initiatives, we've focused on that, collecting that level of granularity that we can drill down on specificity for race, ethnicity, and language challenges. So that's an area that we're continuing to work on for sure. And just getting the voice out there to get more participation among facilities. I think the more engagement we have with stakeholders, the more engagement we have with facilities, the more engagement we have with patients and families, and hearing their voice is going to really take us to the next level for care in Texas.
Yeah, Texas is such a big state and there's so many births. It really is difficult. Everything we do really needs a lot of partnerships to make it successful, because it's hard for a small group to cover a big state like Texas.
Absolutely.
So, Dr. Hall, how can TCHMB make a bigger impact across Texas? How do you see us doing that?
So I think that's a really great question. And I think you can see from over time, as our collaborative has emerged, we have continued to see increased participation of the hospitals within these quality improvement projects, which is really important. I think that we have some really great opportunities around our reach as far as being able to continue to partner. I'm wearing both hats right now, right? The TCHMB hat, but also the Department of State Health Services. And so we know that as we kind of continue to move forward with some of our key programming, the role that the TCHMB plays has an opportunity to have that greater impact across the state as we look into the next bundle that we're rolling out. The role that the TCHMB can play around that sepsis bundle is really going to be important. I think that as we're looking at some of our other areas of focus, and looking at how we engage with the hospitals around, say, for example, breastfeeding or safe sleep, I think we have a really great opportunity to build on some of those successes that we have had with the recent neonatal project to really kind of keep that engagement going with our different hospitals. And so I think that we can really build on the successes and the engagement that we've had to really kind of move forward into a lot of kind of statewide types of initiatives.
Thanks. Yeah, we really appreciate the partnership with DSHS. It really allows us to go a lot further than we could by ourselves. So very much appreciated. So there are several questions coming in. So I'll start off. And the first one, Dr. Hall, is for you. At the TCHMB Summit earlier this year, we heard a little bit about a new data infrastructure integration program related to the data modernization initiative within DSHS. Here at Episcopal Health Foundation, we're very interested in an update about the data project. Do you have any updates to share?
I'm happy to provide some updates. For those that may not be aware, DSHS was awarded about $11 million during the last legislative session to really focus on maternal and child health data modernization, which is really helping us to support those programs that we are legislatively mandated to implement. So that includes maternal health and safety initiatives such as Texas AIM, our support of the Maternal Mortality Review Committee, and then a lot of our data analytics that we do with our data sets that we have here at DSHS. We've really focused initially on two projects. One is the Maternal and Child Health Quality Improvement System, and then the other is the Maternal Mortality Review System. And through the Maternal and Child Health QIS, lots of acronyms here, but that one we're really kind of focusing on those data analytics piece, how we are able to better support our Texas-HAIM hospitals regarding data collection, and then really kind of giving that data back to them. We have successfully been able to implement a process where we are collecting data from hospitals through Qualtrics, where we're collecting those process and structure measures from hospitals, but we are in turn able to then give them their outcome data back through our provisional hospital discharge data. And then that is allowing them to kind of see how they're doing as a hospital. They can see it kind of on the hospital level, but also in aggregate. And we're always working with our partners to kind of understand what those data needs are. We have also successfully launched on Texas Health Data, which I highly encourage everyone to go and take a look at, dashboards related to maternal and child health. That includes infant health and maternal health. If you go there, you will find information on infant mortality, infant health practices such around breastfeeding and safe sleep. You will see analysis related to severe maternal morbidity, along with maternal mortality, as well as some information around Texas-AIM. So those are some of the key things that we have done in regards to that maternal and child health QIS system, but we are continuing to work on that. And we're now really working on how we can have enhanced reporting and data visualizations. Regarding the maternal mortality review system, this is really building a system that will better support our maternal mortality review committee. Right now, we kind of work in bunch of different systems to really kind of get our case review process. This is going to allow us to have all of those different elements in one place. And it's also going to help address some of those things that can slow us down a bit. Like for example, we have to redact here in the state of Texas for cases, and there's going to be an opportunity around having some of that redaction automatically done as we're kind of working through cases. So I welcome everyone to go and check out Texas Health Data, take a look at our dashboards. If you have questions, you have comments, please reach out to us. We're always wanting feedback and to make these as the best that we can make them for our partners.
Thank you. Yeah, we're very excited about those data dashboards as well. And there was another question about providing the link to those dashboards, and we can provide it in the follow-up material. So everyone who attends the webinar today will get that. We can follow up with that. So happy to do that. So I have a question about, and this is maybe for Dr. Ramsey and Dr. Guillory, is how is community patient voice included in the TCHMB initiative? And so y'all referred to it a little bit, but maybe elaborate on that a bit more.
You go first.
Yeah, I can go first. One of the things we have is as Dr. Ramsey mentioned, we have a community committee. And that committee has 2 co-chairs, and they're able to bring in patient voices so that we take into consideration what patients are saying about the specific projects and problems that we're dealing with. In addition to that, at our summit, every year, we make sure we have patient voices that are part of the regional, the summit, where we have about 500 people who are in attendance. And they are well attended, and we're able to actually ask a lot of questions and really gather information that our community really co-chairs are using within that committee.
Yeah, and I would just add, having that voice of the lived experience to inform our QI initiatives is exceptionally important. So at the collaborative level, on the executive committee, we have a non-voting patient advocacy group. The Preeclampsia Foundation is part of that. The March of Dimes is part of that. So we have the organizational patient voice there. As Charleta mentioned, the summits, at least the last 4, we've had patient panel discussions presenting kind of patient experience in the healthcare system, and looking at opportunities for how we as providers can improve our communication, our care for patients. And I think that hearing those stories is so important. I think one opportunity we've discussed at the executive committee level for the collaborative and continue to look at is having actually a patient representative on the panel on our executive committee. Obviously, there's logistical challenges, having kind of a voice that speaks to both maternal, neonatal, and community as one person's a little challenging, and vetting process is something we're looking at, but that is a kind of an aspirational plan, is to have that patient voice a little more implanted on the executive committee. Although within our work groups for like preeclampsia initiative, the neonatal admission project, we've tried to get the patient voice and engagement at that level as well. And the community committee is looking at opportunities for other projects to develop as they go forward.
Dr. Hoelscher, we actually had really a community session at the summit, and we talked about critical congenital heart disease screening. And we were able to get parents really participating in that, mothers who may have lost a child that wasn't picked up, as well as mothers who were, and the outcome was different. So that was very important in informing us about the different projects as we developed the quality improvement project around critical congenital heart disease.
Yes, I have to say those sessions are just, it really gives you a perspective of what we're trying to do. And in terms of neonatal, taking care of the families too, as well as the babies, because the families are going through a lot of uncertainty and anxiety during those periods. So really, I think incorporating the patient voice however we can is really a critical area here for TCHMB. So several people have put in questions or comments about doula work. So especially with the new legislation that's been passed, but recommending it as a QI project or asking what we're doing in terms of that. Who would like to take that one on?
I'll let Dr. No. I think, oh, go on.
No, I think it's the work that doulas do, providing support for families and the birthing persons, is exceptionally important. We currently don't have that voice on our executive committee, but certainly as we work through projects, we bring in stakeholders, as mentioned, to help kind of inform what those initiatives look like and what the interventions are. So that is probably an area that at the collaborative level we could have a little stronger voice with. I know there is a maternal rural health project that's ongoing right now. They'll have a white paper coming out tomorrow, I think. And part of that is how looking at how we can use other obstetric support persons or providers to reach out to patients in the rural areas of the state to improve care. And I know part of the discussions that have been enhancing use of doulas in those rural areas for support, not necessarily medical care. So I think it's an important area to look at. I think it's something, as we have an individual project that evolves, that having doulas, that voice heard, is really important.
I think that there's a lot of information now, and I really just got off of a meeting this morning with the Secretary Advisories Committee on Infant Mortality and Morbidity, and at HRSA, and one of the things they were talking about were doulas. And the things that came up were the importance of their role in supporting the team in caring for mothers. The other thing they talked about was, how do you pay for them? That came up as one of the issues. How do you pay for them? If Medicaid pays for it, is it split between the doctor, the midwife, and the doula? So those are the discussions they had. The other discussion they had was on how do you designate a credential? How do they obtain credentials? In other words, so that they have some means of saying they're boarded in this or whatever. That definitely, those were the 3 topics of discussion this morning nationally on putting doulas in. But everybody agreed they are a critical part of the team. We're at a point now in terms of maternal care that we need all hands on deck. And that means doulas, everyone needs to come in, midwives, everyone, and nurses, doctors, everybody. So those were the things that were discussed.
Excellent. Another question, we've got a lot of questions here. I'm not sure that we'll get through all of them, but what initiatives are in place or planned for reduction of maternal mortality from overdose? Dr. Hall, I know you probably want to take that one.
I'm happy to jump in, and that is a really great question. And so I think that what we have done is through Texas AIM, there's a bundle that was developed at the national level, and then we have been working over the last 18 months to really kind of look at it with a smaller group of kind of hospitals that have already had some existing work in this space. And so we have been working with 8 hospitals across the state of Texas to really look at the best way to implement the bundle around substance use disorder statewide. I would say that one of the things that we learned very quickly is that you cannot separate mental health and substance use disorder. And so our team started bringing in the components from the mental health bundle that were appropriate for the hospital setting into bundle implementation. So we recently had what we call our harvest, where we're looking at having our harvest meeting where we bring these hospitals together and we kind of really learn what we did right, what we did wrong, what we can do it better, and then learn from them on how to best implement this statewide. I had shared earlier, we are looking at the sepsis bundle and rolling it out statewide, but we are also looking at planning around the mental health and substance use disorder bundle, rolling it out statewide as well. And so we are looking to our partners at the TCHMB regarding that bundle. We are looking at it from both an inpatient and an outpatient perspective. And that outpatient perspective will be new because Texas AIM historically has been really focused more on the hospital setting. So those are things that we are working on currently. That we really have an opportunity in partnering with the TCHMB on looking at statewide the AIM bundle as it relates to substance use disorder.
Thanks. Oh, go ahead, Dr. Guillory.
Yeah, I just have one comment, Dr. Hoelscher and Dr. Hall. In this particular bundle, are we screening every mother for substance abuse? Does it affect everybody?
And so there is a component around screening, and so that is part of kind of the bundle itself, and it's implementing how to do those screens and how to do them appropriately. And so that's part of working with those initial 8 hospitals on kind of building out what that would look like, and then how do we have that spread statewide.
Thank you.
So I'm glad you answered that, because someone just sent in a question about perinatal mental health. So anyway, great job of anticipating the question. So we have several questions about kind of contributors or the rates of maternal morbidity or mortality. So I know with the MMMRC report, there's some data in there, but I don't know if y'all want to address some of those.
Sure, I could start, I guess. I encourage everybody to look at the report from the MMRC that was released August 31st, I think, to kind of look at all the findings from the cohort of maternal deaths in 2020, as well as the recommendations. A lot of that's related to reducing disparities, which continue to exist for not only morbidity, but for mortality. Increasing access to care for patients with the extension of Medicaid, that's going to be helpful, but we won't see the impact of that for several years because we're a few years behind in maternal death review right now at the MMRC level. There were some recommendations related to expansion of workforce to not only increase access to patients across the board, but specifically to those rural areas that we know there are healthcare deserts in Texas for maternal care, and trying to have better resourced areas for those patients who live in those areas. So I think we have a lot of opportunities, and the MMRC report is a great roadmap for you all as stakeholders or advocates listening today to come into this legislative session to carry some of those thoughts and opportunities forward as they're relevant to your work, to potentially take us to the next level. We took 3 sessions to get the extension of Medicaid to 12 months, but it's there, and it takes a village to make it happen, and you all are the village that can help us carry us across the finish line for improving care in Texas.
Great. Yeah, thank you for providing that update. And really, that extension of Medicaid is a real game changer for Texas. So very fortunate that that passed, and thanks to the Texas legislature. So we're nearing the end. I wanted to ask a last question about how can people get involved with TCHMB. So I thought I'd ask the panel.
So if it's okay, I'd like to kick us off. I think that there's ways to do it, multiple ways, but one of the things that I look forward to every year is the summit. The TCHMB puts on a summit every year. This summit is fantastic. It brings in clinicians. It brings in, we have family members. We've mentioned earlier, we have panels that include family members. We have folks who are working within the maternal and child health space, students, other folks. And I think it's a really great opportunity to get involved with the TCHMB. I think we get to learn from experts across the United States, but also here in our state, and then really kind of learn from each other. So I think that's one way to get involved, is to come to our summit, which is going to be in June this next year. And there it is. All right.
The other thing that I think we should remember is that we have other opportunities. We have a lot of people who are interested in work, perhaps with the committees. Keep in mind that the Perinatal Advisory Council helped us develop QAPI in all of our hospitals. So there are QI projects there that we could certainly work with within the committee. So neonatal committee, OB committee, data and community, please look into those committees and make sure that you are applying to be part of TCHMB that way. We also, when projects are developing, we can have members that have expertise in that field to really participate as well. So thank you.
And I would add, just being here today, listening to this webinar is a first step toward that. And for those hospital partners that are here today, your maternal and neonatal program manager, your maternal and neonatal medical directors all sit on the Regional Advisory Council for your perinatal committee. So reach out to them and get involved at the RAC level, because as I mentioned, each RAC for the facility has a representative on the obstetric and neonatal committees. And then for community, we're always looking for individuals interested in serving on the committee. But even at the RAC level, there's opportunities. We need that community voice, that lived experience voice at that level to bring ideas forward for the collaborative, for opportunities for improvement. And as Charleta mentioned, we have work groups working on all the initiatives that the collaborative puts forward, not necessarily run by the committee itself, but we put interested individuals on those work groups to help. So if you're interested, the RAC's another spot to get involved with, and certainly let the leadership of your RAC know that you're interested in maybe serving on the obstetric or neonatal committee. And if you're community advocate out there, certainly apply for positions as they open through that committee.
Thank you. And I think the next slide actually has a QR code where you can get involved with us further. So we're right at time. I wanted to thank everyone for being on the webinar today. We've also got a lot of questions we didn't get to, so we'll follow up on those afterwards. A lot of great suggestions too for future work and future partnerships. So thank you very much for contributing that way. We talked about the summit, so make sure and look for that. There's going to be a lot of information coming out about that soon. Save the date. I wanted to thank our panelists. They're all very busy people, and we're very fortunate to get them all in one place at the same time, and really for sharing your expertise and with us for this webinar. So as we all know, healthy mothers and healthy babies, that's what we all want for a healthy Texas. So thanks again for joining us. We will archive this on our msdcenter.org website, and we'll send out information to everyone who's been on this webinar. So thanks so much, and thanks to the panelists, and have a great day. Y'all take care. Bye-bye.
Thank you.